Okay, thank you, Divya. Okay, so we're going to be talking about surgical presentations, which is basically a lot of GI presentations. Okay, so you've seen this slide before, and we're going to be covering dysphagia, nausea and vomiting, hematemesis, PR bleed, epigastric pain, abdo pain, change in bowel habit, and groin lump. Okay, so, and you've seen the slide before, but I've just kept it in. So yeah, this is the main steps to it, and I've got a more specific GI one here. So the general OSCE, you want to start the station and then get the patient to tell you what's going on, and then you want to listen to their presenting complaint. And the main thing to get out of it is that we don't want to miss any of the dangerous things. So have a think about when you're waiting outside for whatever presentation it is like what dangerous diagnoses that I don't want to miss. And then think about what key questions there are. So for example, in the GI, you can just narrow down the different GI presentations and then also like the red flag symptoms. And then in the OSCE, they might ask you a bit about the investigations you might want to do. And we'll have a talk through all of these. Yeah. Okay. And then with GI stuff, it's always good to ask about any weight loss, any dysphagia, GI bleeding, persistent vomiting, change in bowel habit, anemia symptoms, fever sepsis, and severe or worsening pain. Okay. So we'll start with dysphagia. Hopefully today we'll go through it quite quickly. A lot of it's quite repetitive. Okay. So with dysphagia, there are a few different. So actually, I'll start off with what is dysphagia. So that is having difficulty swallowing. And when someone says that, it could be many things. So you can just ask for specifics. And when we get in there, you want to think about these different. There's a lot of presentations there could be, but I split them up into the main ones of malignancies that we don't want to miss. And then on top of those, you also have the mechanical obstruction. So there's literally something just stopping them from swallowing things. And then there's also where the esophagus is having trouble, like it's constricted, so it stops letting things through. And then just things around it, compressing it as well. Okay, so how do we differentiate from these? So the main question is it solids, liquids, or both? Okay, so I need to start by also asking, has it started with solids and then progressed to liquids? So if is it progressive or are the symptoms coming and going? And then is it painful to swallow as well? So is there pain associated? And then there's also the sensation of food sticking in there. Is it getting stuck? Where is it getting stuck? You could ask a bit about that. It's not really easy to localize, but that's sometimes helpful. And then is it sticking and then going down, or is it sticking and then they have to vomit it up? So regurgitation, and then also useful to ask about any reflux symptoms, as that might be causing what is going on in the esophagus. And then, of course, you need to ask about any weight loss. And then also, if you're over 55, okay, I think I have the red flags on the next page. And then, so with all questions, OSCEs, you also ask about the past medical history. So here, the ones that are relevant could be gastroesophageal reflux disease. So that irritating the esophagus, causing it difficult to swallow, including caustic ingestion, so just damaging your esophagus through other chemicals. Radiotherapy or surgery can link to like strictures and adhesions, and then thinking about stroke and neurological disease as when you find it difficult to swallow, it could be difficult to swallow down there, or it could be at the top where it's difficult to swallow. So stroke and neurological disease can also make it harder to swallow. And then some drugs associated with, I guess, reflux as well, acid reflux. And then smoking and alcohol is always useful to ask. And then any family history of upper GI cancer. Okay, so what I find useful with things is listening to signs and then what those signs mean. So, for example, if it's solids only, it's likely it's an obstruction because liquids still pass down. And then if it's solids and liquids, motility, progressive cancer or stricture. If it's intermittent, it could be a ring, spasm. Eosinophilic esophagitis is sort of similar. But there's specific tests for it. So, and if there's pain, it's often infection or inflammation. And then with regurgitation, we're thinking about achalasia and or a pouch, like a pharyngeal pouch. Okay, so with these signs, you can like sort of link them to what they suggest. Okay, and now the red flags you want to ask about are the progressive symptoms. So these suggest sort of malignancy, and you don't want to miss malignancy. So, and then also you don't want to miss bleeding. So if they're at risk of bleeding, so anemia, which is also a sign of malignancy. And then another key thing is unsafe swallowing, which is often missed. Because swallowing, you can get aspiration pneumonia. So you need to ask about if they cough whilst eating, if they have any choking episodes, or have any recurrent chest infections, which are signs that they've had previous unsafe swallowing. And here's the list of lists of things you can like rule out. So important to ask if they're just experiencing any of these. Okay. So when they ask after the history and you ask about, oh, let me move this. So after the history, they ask you about investigations you could do. So you want to move from the bedside to like gradually further away. So at the bedside, you can do a neck exam, you can do an abdo exam to have a see, so you can look in their mouth. And then some bloods you could do. So full blood count is important to rule out anemia. And then using ease, you can assess their dehydration or nutritional status. I find with OSCEs, they sometimes ask you for what investigations you want to do, and it's useful to think about why you'd want to do them. So it helps you remember, and they might ask you as well, like, why would you do a UNE? Okay, and then an OGD, which is the camera, so you can visualize what's going on and see if there's anything suspicious looking, and then also biopsy it at the same time. And then with the barium swallow, you can have a see of what sort of shape the esophagus is looking. And from you can probably know that achalasia shows the bird beak shape, which is I should probably have a picture, but a bird beak shape. And then the pharyngeal pouch shows like a little bit going off to the side, getting stored on the side. And then manometry, you can suggest as well. That measures the muscle contractions. And then also a CC chest and abdo to stage for cancer. So, and you can see how thick the cancer has spread to. Okay. So with the management, you want to assess if they have a safe swallow, and then you might want to put them nil by mouth if they have an aspiration risk. So IV fluids, give them IV fluids if they're dehydrated, and nutritional support. So that's initial, that's managing their symptoms and what's worrying at the moment. And then for core specific ones, with cancer, you'd want an MDT, CT to stage, and then plan for surgery, oncology, or palliation. With a stricture, that could be caused by the reflux. You'd want to give them a PPI, can dilate it, and then can biopsy it to see what is going on there. And then achalasia, similarly, you can dilate it with a balloon or like cut the muscle, and that opens it up a bit. Esophagitis and GORD, it's PPI and lifestyle, and then you have to treat the cause. And then if there's a food bolus stuck there, you want an endoscopy to retrieve it. Okay, so I'm gonna try and start the OSME. Oh, unless it started already. Yep. So, have people managed to join? Okay. One person's joined. Four people have joined. Okay. Oh, hmm. Should probably not do this on my phone. Hmm. Okay. Okay. Everyone have a go at the question. Okay. Can see everyone's got it right so far. Um, okay. Hmm. Oh, there we go. I see how to look at it now. Okay, so the question is, a 68-year-old man presents with 3 months history of worsening dysphagia. Currently, um, initially he struggled with meat and bread, but now he struggles with most solid foods. And he's lost 8 kilograms, feels increasingly tired, and he has a 45-pack-year smoke history, 35 units of alcohol per week. What is the most likely diagnosis? Okay, and yep, everyone try and have a go. And with reading the like vignettes, you can see that it slowly adds together. So 68-year-old man. So it's a over 55-year-old who's getting new symptoms, has a progressive worsening dysphagia, and he's lost 8 kilograms, increasingly tired, and then his social history as well. So you can see how each point kind of builds up to the case of what you think it might be. And yeah, it is B. Really good. Okay, and then let me try move on to number two. Okay, number two is a 42-year-old woman presents with intermittent dysphagia affecting both solids and liquids from the start. She describes regurgitating undigested food at night and has several episodes of coughing after lying down. She has no weight loss and no smoking history. What is the most likely diagnosis? These are probably very um, okay, and hopefully these will the explanations are helpful as well. Okay, so for this one, it's achalasia. Um, and yeah, so solids and liquids from the start. So not very progressive. It's intermittent, and it's got some undigested food. So there's regurgitation. Um, okay, and barium solid might show bird beak. Okay, so that is dysphagia. Okay, nausea and vomiting, very, very broad. So it's so I've split it here into the differential diagnosis it could be. So when you see nausea and vomiting, have a think about these when you're outside the OSCE station, for example. So it could be bowel obstruction, appendicitis, something related to gallbladder, pancreatitis, perforated ulcer. And then some medical/metabolic reasons could be gastroenteritis, DKA, uremia, hypercalcemia, pregnancy. And then there's also neurological reasons such as increased intracranial pressure and vestibular causes. So if they're particularly dizzy, could make them feel sick. And then also drug-related reasons. So opioids, antibiotics, and then post-operative ileus. So it's just like sort of not a mechanical bowel obstruction, like a physical one. It's just not moving stuff down. Okay. And then with nausea and vomiting, the key questions here are about the onset, duration, frequency, and the volume. So you want to also know about vomit content. Vomit content can be very useful. So if it's undigested food, it could be something at the stomach. So it could be a gastric outlet obstruction or gastroparesis. So it's just not moving down, not being digested. Bilious vomiting, you also learn later on to be really useful to mean like a small bowel obstruction. It means that food has moved past the ampulla of Vata or something like that, and bile has been added to it, and then it's been vomited back up. If there's blood in the vomit, so what type of blood? You need to ask if it's fresh blood, so that suggests active GI bleeding, and then coffee ground blood, so darker brown, brown bits suggest there's more, suggest like more like old bleeding, but it's managed to come up. And then feculent suggests distal obstruction, so the fecal matter has come up as well. And then if the vomiting is related to meals or not, so if there's pain associated with it, ask about Socrates. Socrates is actually so useful. And then distension, so and then bowel opening, or if they've passed wind or not, that's important as it also suggests if there's any obstruction, if they have fever or diarrhea, drugs, pregnancy, jaundice, and vertigo. So all of these are signs for the previous differentials that we had. So, and important little bits to ask about as well are if there's been any previous abdominal surgery, if they have diabetes, that could be DKA, gallstones, peptic ulcer disease, and then if they actually have any history of raised intracranial pressure, and then take a drug history, that could be a clue. And then with nausea and vomiting, travel's a bit more relevant. There could be maybe gastroenteritis related, and then also, food exposure, sick contact, so social history, and those points. I've got another, here's the slide on vomit content and what it might suggest. Okay, as well, projectile vomiting might suggest an obstruction too. Okay, and then how they are added together. So if you have distension and constipation, it's really important to think about obstruction as that as an emergency. So distension, constipation, ask if they've passed wind or not. So, and then if they feel epigastric fullness in particular, then there could be gastric outlet obstruction. Diarrhea and fever suggest an infection, so gastroenteritis. They also feel dizziness, vestibular. And then if they are associated with polyuria, polydipsia, ask to check their blood glucose. History of diabetes could be DKA, and then weight loss, think about malignancy, so weight loss, fatigue, and night sweats there. Okay, and here are the things to look out for. So if there's any shock or dehydration, they could be very dehydrated from vomiting the whole time and not being able to get any fluids in. So if they have severe abdominal pain and peritonism, and that is if you press the abdomen, there's lots of guarding, and then rebound tenderness as well, and persistent vomiting, and then the blood and vomit is a key thing. Okay, and then these two are for obstruction. Okay, and things to investigate with. So you want the full blood count and CRP to check for infection, using these for dehydration, can detect AKIs, and then LFTs for any biliary causes, and amylase or lipase for pancreatitis, glucose ketones, BBG for DKA, or also if it's a woman of reproductive age, do a pregnancy test, and then chest X-ray, CT. You can see for the gas bubble right below the diagram, which suggests a perforation, and then abdominal X-ray. You can also see any obstruction as well. If the bowels becomes dilated somewhere, you can see potentially. And then OGD as well, so camera, and you can see if there's any kind of upper GI obstruction there or bleeding. Okay, and then management, the initial management is A to E, which you'll know well by the end of fifth year. And then with the other ones, you just correct the things that have gone wrong. Okay, and I'm going through the management very briefly, just so because in fourth year you don't really need to know the management, just very basics if they ever ask it. But if you're thinking obstruction, then they're going to need surgery. So keep them nil by mouth, give them an NG tube to help them get rid of whatever's in their stomach, might help stop them vomiting as much. And then you'd want to request a CT abdomen and a surgical review for that. And to try go back onto OSME on Socrative. Next questions. Oh, yeah, you can. Wow, okay. So, a 74-year-old man presents with 24 hours of vomiting, abdominal distension, colicky, abdominal pain. He has not opened his bowels or plater since yesterday. He had a right hemicolectomy 5 years ago. What is the most likely diagnosis? Okay, and this one is most likely small bowel obstruction. So the clues here are, I guess, the vomiting, abdominal distension, so cannot get rid of anything inside the stomach, the abdominal pain, colicky, because I guess it's trying to contract, but it just cannot pass, it cannot get through. Okay, and then he's not opened his bowels or flatus, so nothing's gone through. And then right hemicolectomy, so surgical history also suggests obstruction because likely to form adhesions. Okay. And then the next one, 58-year-old man presents with repeated vomiting. The vomit is described as dark green. He has central abdominal pain and has not passed flatus. His abdomen is distended. What does the vomit content most strongly suggest? Okay, so this one's again a very similar presentation to the other one. Okay, and it is small bowel obstruction because it is bilious. So if it's green, it's past the ampulla vata, so it's in the small bowel. So not less likely to be gastric outlet. Gastric outlet would be more undigested food. Okay, back to the slides. Okay, now this time it's specifically hematemesis, so blood in the vomit. So what is the differential diagnosis there? So for upper GI mucosal disease, so you can have peptic ulcer disease, gastritis, and duodenitis, esophagitis, and vascular/portal hypertension, esophageal varices. There are Mallory-Weiss tears, could be a malignancy, esophageal cancer, gastric cancer, and then could be swallowed blood from above. Okay, so does it look fresh or coffee ground? Again, volume, frequency. If they've also got melena, so dark tar like poo, collapse or syncope. So if they're, I guess that's a sign of if they've lost a lot of blood. Retching before retching suggests it could be a tear. Actually, I should probably move on to the next slide to see the associations. Okay, but quickly, past medical history, it's important to ask about, for example, liver disease or if they've had any previous GI bleeds. Drug history is important for the peptic ulcers, NSAIDs, and steroids can be bad for them. So are bisphosphonates, and then social history, and then family history, also relevant bits. Okay, so again, here are what some answers might suggest. So fresh blood, active bleed, coffee ground, slower upper GI bleed. Melena, also upper GI bleed, so it's also going down into the getting formed into the poo, digested. And then retchings, then blood suggest the Maori-Weiss test. So there's some sort of causing some sort of trauma. And then there's NSAIDs, pain, peptic ulcer, and cirrhosis, previous cirrhosis, alcohol history, esophageal varices, and then weight loss malignancy again. Okay. So key investigations to do are any OBS, A to E to rule out shock, full blood count again here, rule out anemia, any coagulopathies, E's and E's, can look for urea, which is a sign of digested blood, or yeah, and then LFTs and clotting to see the liver function. And it's important to group and save and cross-match to prepare for transfusion, and lactate to see if there's any hyperperfusion. So that's seeing if they've lost a lot of blood as well. So that's a sign of losing lots of blood. And then an OGD is used to diagnose and also treat it. Okay, so you can read this as well, but let's go back to the questions. Okay, so number 5, alcohol-related cirrhosis, vomiting large volume of fresh red blood. He is dizzy and clammy. His abdomen is distended, visible abdominal veins. And then what is the most likely cause of his hematemesis? Okay, so the clues here are the cirrhosis, alcohol-related cirrhosis, fresh blood. He has got visible abdominal veins, so he's signs that he's got varices already. So caput medusa, that's what it's like a sign of. So most likely for this one is esophageal varices. Yes. Okay, and then quickly, the next one is 31-year-old woman presents after vomiting blood. She has been repeatedly retching after drinking alcohol the previous night. She is hemodynamically stable and has no history of liver disease. What is the most likely diagnosis? Okay, so this one, the clue was retching after drinking alcohol, causing strain. So most likely to be a mucosal tear at the gastroesophageal junction, which is a Mallory-Weiss tear. So B. Okay, so many little clues to suggest things. Okay, and then PR bleeding. So PR bleeding could come from a few places. So it could be right on the outskirts. So it could be benign anorectal, so hemorrhoids and anal fissures. And then it could be coming from inside the colon. So it could be a diverticular bleed, colorectal cancer, polyps, angiodysplasia, inflammatory or infective. So IBD, infective colitis, ischemic colitis. There's also such thing as chemotherapy-related colitis. And then others could be rectal prolapse and upper GI bleed. and it's just managed to get through the GI system really quickly. Okay, so the questions you want to help differentiate from those is the color of the blood, and then if it's mixed in with a stool, or just on the surface, and then is it just if they're wiping or is it in the pan? So that kind of suggests the amount, and then if there's pain with it associated, any melena, so that's kind of if it's mixed in with the stool or not. And then if there's diarrhea associated and mucus, if there's been any change in bowel habit, and then weight loss again. And then here's some things that can suggest. So past medical history and family history, if there's any history of these sort of diseases. So bowel cancer, IBD, quite useful. Okay. So if it's bright red on wiping, it suggests it's kind of not that much and it's very superficial. So most likely a fissure or hemorrhoids. Hemorrhoids is not painful. So painful ones are associated with fissures. So just on the anus, there's like a opening which can bleed. And then yeah, painless is hemorrhoids. Diverticular disease can also lead to painless fresh bleeding. So that needs to be investigated. So if there's blood mixed with the stool, that can suggest cancer and colitis because it's further up inside the colon. And then if there's blood and mucus around the stool, then suggests more IBD or an infection is upper GI bleed. Okay. PR bleed, red flags. So worrying things are, of course, if they've lost a lot of blood, and then the cancer red flags, which are weight loss and change in bowel habit, could be various things, but ask about progression and things. And then, of course, a mass is also very worrying for cancer. And family history is also useful in this case, as there's familially related ones like polyposis and Lynch, I think. Okay, so how to investigate a PR bleed. So you need to do a DRE and proctoscopy to just visualize anything, if there's anything like close to the opening, and then FBC and ferritin to check for anemia, iron deficiency, and then using these LFTs and clotting, can check their bleeding risk. So in drugs, ask about if they've lost any blood. Oh no, so in bleeding risk, can ask if they have any coagulopathies, if they're on any anticoagulants, for example, and then CRP and stool test. So fecal calprotectin is a sign of inflammation in the bowel. So that one's a useful one for IBD sometimes. FIT test screens for colorectal cancer, but I guess with this presentation, it's kind of visible bleeding of some sort. So a FIT test may just be positive here, but FIT test is useful for colorectal cancer screening. And then later on, to investigate further, you do a colonoscopy, and then also CT angiography can be used to visualize active major bleeding. Okay, and then quick management. So fissures are often associated with constipation and hard stools. So stool softener can help with the pain and then stop opening up the fissure again. And topical treatment can also make the vessels smaller. Hemorrhoids can be conservative, also with creams and things. And then there's also surgical methods of managing hemorrhoids. IBD, do a gastro referral. And if there's a cancer concern, do the urgent 2-week wait pathway. And then major bleeds won't turn up on your OSCE. Okay, so back to the questions. Okay, so a 24-year-old woman presents with bright red blood on wiping. She has severe pain and avoids going to the toilet because of the pain. Most likely diagnosis. Okay, so yeah, that is most likely going to be an anal fissure. So you've seen from the bright red blood and then pain as well. Okay. Next one is a 67-year-old man presents with PR bleeding. He reports that the blood is mixed in with the stool. Over the past 2 months, he has developed looser stools, reduced appetite, and 6 kilogram weight loss. So what is the most likely diagnosis? Okay, so yeah, this one's got many red flags for colorectal cancer. So you've got a change in bowel habits, reduced appetite, weight loss, and the blood is mixed in with the stool, which suggests it's inside the colon. Okay. Okay, next one is epigastric pain. Okay, so epigastric pain. So think about the organs in that region. It could be upper GI, so GORD, gastritis, peptic ulcer disease, esophagitis, gastric cancer, and then biliary, pancreas is also there, so pancreatitis, cholecystitis, biliary colic, and hepatitis. And then it could also be cardiac, so inferior MI, and then abdominal aneurysm as well. Yeah. And then it could also be functional dyspepsia, which is kind of heartburn. Okay, so with pain, just use Socrates. And the things to think about here are if it's what type of pain, so burning or sharp pain, so heartburn, relation to meals, is it before a meal? Yeah, okay. And then if there's any reflux or regurgitation, if it radiates to the back or not, and then if there's any right shoulder pain, okay, and then vomiting, early satiety, and then NSAIDs and alcohol, also peptic ulcer disease. Okay, and then the red flags to ask about are any peritonism, hematemesis, melena. So all the stuff we've covered before, they always come back in all the presentations. So can quickly run through them with the patient, just asking if they have any of them. And then other ones give clues to what could be causing it. So jaundice are more likely to be a liver or gallstone related thing. Okay, and then chest pain and shortness of breath, important to ask about because you think you're on a GI station, but then it's chest, it's an MI. Okay, so burning and reflux suggests gastric and esophageal reflux disease, meal-related pain, peptic ulcer disease, radiating to the back, likely to be a pancreatitis or a posterior ulcer, but usually it suggests pancreatitis. So any right upper quadrant, right shoulder pain suggests biliary disease because it's in that region. And then if there's inflammation in the liver, it can stretch it and then cause pain there particularly. Sudden pain, so how it came on also suggests could be perforation, and then vomiting, early satiety, cancer or gastric outlet obstruction, and then exertional pressure. So if they've got it after doing some exercise, then more likely to be acute coronary syndrome, so heart related. Okay, so what you want to do is ECG, troponin to rule out acute coronary syndrome. We want to do a full blood count and so rule out anemia, and then you can also see the white cells, so infection. CRP would be useful there as well, actually. And then using these LFTs for the biliary stuff, and then amylase and lipase for pancreatitis. And then H. pylori test is useful for search for a potential cause of peptic ulcer disease. And then chest X-ray and CT to see for any perforation or free air in the abdomen. Okay. And then ultrasound scan for gallstones initially, and then that again, OGD, again, camera to look for, directly visualize any potential malignancies or bleeding. Okay. So back to the questions. Okay, so a 63-year-old man presents with severe epigastric pain radiating through to his back. He has vomited twice and he drinks 45 units of alcohol per week. His serum lipase is markedly raised. What is the most likely diagnosis? Okay, I see a lot of people have answered already. So, epigastric pain radial to the back, heavy alcohol intake, lipase as well suggests um, pancreatitis. Okay, and then a 58-year-old man presents with epigastric discomfort and nausea. The pain occurs when he walks uphill, settles when he rests. He has type 2 diabetes, hypertension. What is the most important diagnosis to exclude? Okay, yes. So it is, um, this one is acute coronary syndrome. So the exertional pain and shortness of breath. So, but it can present in the epigastrium. So that can be very confusing, but well done. Okay. Next bit, it is abdominal pain. Sorry, this is very repetitive, but soon you'll have all the presentations and they'll all overlap. Okay, so surgical emergencies include appendicitis, perforated bowel, bowel obstruction, mesenteric ischemia, and erupted abdominal aorta aneurysm. Okay, and then inflammatory could be cholecystitis, diverticulitis, gastroenteritis, pancreatitis, or an IBD flare. Renal/urinary could be renal colic, pyelonephritis, and then gynae or testicular could be an ectopic pregnancy, ovarian torsion, testicular torsion. So these are all things as well. They're all in the abdomen, so could be any of these things. So there's a lot broad differential to rule out here. Okay, so Socrates again. So constant, or is it colicky, comes and goes. Is there any migration of the pain? Does it happen with any vomiting or distension? Have bowels been okay? Passing wind? Have you had any fever with it? And then ask about any urinary symptoms. So pain when passing urine, any blood in the urine, gynae symptoms. I'm not sure that will come up, but you should always ask if there's any possibility they could be pregnant. Yeah, and suggest doing a pregnancy test in the investigations. Okay, so colicky again should make you think about obstruction. If it's constant and worsening, will be more inflammation. If it's sudden and severe, suggest perforation or ischemia. And then if it's central, then moves to the right iliac fossa, suggests appendicitis. Right upper quadrant after meals, gallstones. Lower iliac fossa and bowel change suggests diverticulitis. And then pain out of proportion, you need to think about ischemia, mesenteric ischemia as well. And previously in the history, that's thinking about aneurysms and vascular disease. That is so, and for example, if they have any like atrial fibrillation, more likely to be mesenteric ischemia. Okay, the red flags, possibly the same as before, except pulsatile mass, that's like for the abdominal aorta aneurysm. Okay, so you would want to do an abdo exam, urine dip to check for UTI or any stones. So if there's any tiny bit of blood in there and they're not a woman, then could be stones, irritated the ureters. Pregnancy test to rule out ectopic pregnancy, FBC CRP just to check for infection or inflammation markers, using these, LFTs lipase, BBG and lactate is useful for if there's any sepsis or ischemia. They are lactate is raised in both of these. Abdo X-ray, chest X-ray can look for obstruction or if there's any free air in the abdomen. And then ultrasound is super useful here as well. It's useful for gynae pathology. You can see the abdominal aorta and also the gallbladder if there's any stones there. And then CT abdo-pelvis for any further surgical pathology. Okay. So, a 21-year-old man presents with abdominal pain that began around the umbilicus and later moved to the right iliac fossa. He feels nauseated and has a low-grade fever. On examination, there is tenderness in the right iliac fossa. What is the most likely diagnosis? Okay, so the clues here are the central abdominal pain migrating to the right iliac fossa, and then nauseated low-grade fever, suggesting maybe inflammation, and then there's also tenderness there. So yeah, it is appendicitis. Well done. And so bloods might show raised white cell count, CRP, and then you'd want to do maybe an ultrasound to have a look or a CT to support the diagnosis. Okay. Then we have a 77-year-old atrial fibrillation, sudden severe abdominal pain, and then his abdomen is soft, minimal tenderness, lactate is raised. Okay, so this hits all the points for mesenteric ischemia. So we have a atrial fibrillation which might send off clots, thromboses, emboli, and then it gets lodged in the vessels causing mesenteric ischemia. Okay. Okay, change in bowel habit. Okay, only change in bowel habit and one more after this, which is groin lumps. So change in bowel habit can also be many different things. So it could be colorectal cancer, IBS, IBD, celiac disease, gastroenteritis. Okay, other GI pathologies, diverticular disease, malabsorption, pancreatic insufficiency, and then thyroid disease, medication, and then overflow diarrhea from constipation. Okay, so change in bowel habit is very broad. So is it diarrhea or is it constipation? And then how long have they had it for? Has it always been just diarrhea or constipation? Or is it sometimes constipation and then sometimes you get diarrhea? You need to ask about stool frequency, consistency. You might be able to get one of the charts and see what type of stool it is. There's blood or mucus in there. If they have feel like they've not finished going to the bathroom after they have emptied their bowels, and then the cancer symptoms. Okay. So blood and mucus could suggest IBD, cancer or infection. Nocturnal diarrhea, so it only happens at night, suggests more organic disease rather than infective. And then tenesmus, which is not feel like it's finished, is more likely to be a rectal pathology. Weight loss suggests cancer or IBD, and then pain relieved by passing the stool suggests IBS, so irritable bowel syndrome. And then antibiotics could be, if they've just had a treatment with antibiotics, it could be C. difficile. And then if it's alternating, then it could be many things still, but it could also be obstruction with overflow diarrhea. Okay, again, these red flags, I think they were on the previous slide anyway. Okay, investigations, very similarly, full blood count, ferritin, anemia suggests to look for anemia or iron deficiency, CRP, ESR to look at inflammation, B's and E's, LFTs, TFTs for any systemic causes of these, because thyroid function actually impacts the bowel. And then we have a celiac screen for malabsorption, and then FIT test to look for any blood in the stool suggesting cancer, just the screen for cancer. And then calprotectin, so stool test to see if there's any inflammation, which if there is inflammation, it sort of rules out IBS. Okay, and then stool culture to check for infection, and then also colonoscopy and biopsy if there's any lesions that want to be seen. Okay, nearly there now. So here we have a 32-year-old woman reports intermittent abdominal pain and alternating diarrhea and constipation for 8 months. It improves after opening her bowel. She has no weight loss, rectal bleeding, or nocturnal symptoms. Blood tests are normal. What is the most likely diagnosis? Yeah, IBS. So IBS is often alternating diarrhea and constipation. The pain often improves after opening their bowels, and then there's no red flag symptoms, and blood tests are also normal. Okay. Next one, 26-year-old man presents with diarrhea, blood and mucus in the stool, abdominal pain, and weight loss. He also reports mouth ulcers and painful eyes. What is the most likely diagnosis? Yeah, well done. So that is IBD. Yeah. So they have blood and mucus, likely to have calprotectin positive, and then the extra, I guess, abdominal signs are the mouth ulcers and the painful red eyes. Okay, last little bit on groin lumps now. Okay, so different hernias. There's inguinal hernias, femoral hernias. It could be enlarged lymph nodes, and then it could be a vascular, so a saphenopharynx, femoral artery aneurysm, and then other things that could be lipoma, abscess, undescended testes, and then hydrocele, varicocele extending into the groin. So swellings of the testicles that are going into the groin then. Okay, so ask, where is the lump? Can it come and go? Can you feel it increasing when you cough? So can you push it back in? Is it painful? Is it associated with vomiting and distension? And then bowels, and if you're passing wind or not, and then if there's any scrotal or testicular symptoms, and then also if the lesion is pulsatile. Okay. So things you can ask for, their occupation, if they do any heavy lifting, and then if there's any connective tissue diseases as well, or risks for hernias. Okay, so the answer suggests is that if it comes and goes, it could be a hernia. If there's a cough impulse, when they cough, it comes out, the hernia. If it's reducible, it's an uncomplicated hernia. Irreducible, it means it's an incarcerated hernia. And now, if it's painful and tender, it's strangulation. And then if there's vomiting and distension in the abdomen, and they've not had any bowel movements, then it might be obstructed. And then if it's below the pubic tubercle, then it's a femoral hernia. Okay. Oh, and then also more patterns. So reducible and cough impulse, likely inguinal/femoral hernia, tender irreducible lump, strangulated or incarcerated hernia. If it's pulsatile, femoral aneurysm. If there's blue tinge, that's likely to be the saphenopharynx, so a massive varicose vein. If it's very firm and the systemic symptoms, then you need to check for malignancy. So that could be a lymph node. That's so lymphoma as well. And then if there's scrotal swelling associated, you can see if it transilluminates, if it looks like a bag of worms, and etc. Okay. Yeah, these are the red flags. Okay. Investigations are the abdo exam. You can do it. See if it changes from standing up to lying down, and then check for reducibility. Do a scrotal testicular exam, and then again FBC CRP to look for infection, and then use an VB lactate to look for dehydration and ischemia, and then ultrasound to see what it is inside, and then Doppler ultrasound to see if the vasculature, and then CT abdo-pelvis for if there's any obstructions or complications related to it. Okay, and now last two questions. Okay, most of you answered already. So we have a 64-year-old woman presents with a painful lump in the right groin. The lump lies below the pubic tubercle and has vomited twice, not open to bowels today, most likely diagnosis. So that is likely to be a femoral hernia, and it's likely to have been obstructed her bowels. Okay, so that needs surgical repair. And then a 72-year-old man presents with a soft groin lump that disappears when he lies down. It has a bluish tinge and a cough impulse. It is located near the saphenofemoral junction. What is the most likely diagnosis? Yeah, so this is most likely to be saphenopharynx. And that is like a massive varicose vein near the top of the leg. Okay, that is all. So for any feedback and the slides, just click on or just take a picture of the QR code. But thanks for coming. Okay. Does anyone have any questions?